This module covers the abnormally fast heart rhythm originating above the ventricles known as supraventricular tachycardia or SVT. SVT is most commonly caused by a re-entry mechanism that involves an accessory pathway or the AV conduction system. It is characterized by a narrow QRS complex on an EKG. Signs of SVT include tachypnea, increased work of breathing, grunting, tachycardia, delayed capillary refill time, weak peripheral pulse, cool extremities, hypotension, and jugular venous distension. With regard to heart rate and how SVT characteristically presents on an ECG, there is no beat-to-beat variability with activity. Infants' heart rates can present greater than or equal to 220 beats per minute, and children can present with heart rates greater than or equal to 180 beats per minute. P waves on the ECG are either absent or abnormal, and they may appear after the QRS complex. Anticipate the need for medications depending on the type of rhythm disturbance. The team will simultaneously try to identify and treat the reversible causes of SVT. There are emergency interventions for SVT. Vagal maneuvers are often used to try to convert the SVT to a normal rhythm. Vagal maneuvers slow conduction through the AV node. If the rhythm does not convert after the second attempt, select another method or provide medication therapy. Vagal maneuvers include ice to the face, the Valsalva maneuver, and carotid massage. Cardioversion is another mechanism to try to convert SVT into a normal rhythm. Cardioversion involves synchronized shocks in patients with SVT and a pulse. The shock is delivered to coincide with the R wave of the QRS complex. Medications are often used to treat SVT, and adenosine is the drug of choice. It's effective for SVT caused by re-entry at the AV node. It also may be helpful in distinguishing atrial flutter from SVT. Adenosine is not effective for treatment of tachycardia caused by mechanisms other than re-entry through the AV node. Adenosine works by blocking conduction through the AV node temporarily for about 10 seconds. Administer adenosine as a rapid IV bolus over 1 to 2 seconds at a peripheral IV site closest to the patient's heart, and follow each bolus with a normal saline flush. The flush is needed since the half-life of adenosine is seconds. For infants, children, and adolescents weighing less than 50 kilograms, the dose is 0.1 milligrams per kilogram, with a maximum dose of 6 milligrams as a rapid bolus. If there is no effect, repeat at 0.2 milligrams per kilogram with a maximum dose of 12 milligrams. For children and adolescents greater than or equal to 50 kilograms, and for adults, the dose is 6 milligrams. If 6 milligrams is not effective, within 1 to 2 minutes, 12 milligrams may be given. Amiodarone may be used for the treatment of hemodynamically stable SVT refractory to vagal maneuvers and adenosine. It works by inhibiting alpha and beta adrenergic receptors, producing vasodilation and AV nodal suppression. It inhibits the outward potassium current, so it prolongs the QT interval. It inhibits sodium channels, which slows conduction in the ventricles and prolongs the QRS duration. Rapid administration of amiodarone may cause vasodilation and hypotension, heart block, or polymorphic ventricular tachycardia. Procainamide is used to terminate SVT that is resistant to other drugs, as well as treatment of hemodynamically stable SVT refractory to vagal maneuvers and adenosine. Procainamide is dosed 15 milligrams per kilogram over 30 to 60 minutes, not to exceed 50 milligrams per minute. with continuous ECG monitoring and frequent blood pressure monitoring. Infuse slowly to avoid toxicity from heart block, hypotension, and prolongation of the QT interval. Dilute loading doses to a maximum concentration of 20 milligrams to 30 milligrams per ml. This concludes the module on SVT. You may review it again at any time.